next session, which is on GI surgery research in the last 1 year. And for that, we are welcoming our chairpersons, Dr. H. Ramesh, Dr. T.D. Yadav, Dr. Sunil Kumar, and Dr. C. Khandelwal. I repeat, Dr. H. Ramesh, Dr. T.D. Yadav, Dr. Sunil Kumar, and Dr. C. Khandelwal. And from here, we are handing over our session to our chairpersons.
Good afternoon, ladies and gentlemen. And it's customary during the annual conference to have a review of the last year's landmark publications, and this is a hugely popular session. And today we have 3 divisions. May I, without much delay, call Dr. Vaibhav Varshney to tell us what's new in upper GI. Dr. Vaibhav.
At the outset, I would like to thank the organizing committee for giving me this opportunity to present the recommended reading in upper GI surgery in last 1 year. So I will cover this topic with cross trial, the RAMI trial, and the usage of ICG during esophagectomy, and the class 01 trial. So as we all know, the cross trial, which was one of the important landmark paper in esophagus, so they came with their 10-year outcome, which was published in Journal of Clinical Oncology with impact factor of more than 44. And this is the only completed randomized trial in the field of esophagus and OG junction cancer with a follow-up of more than 10 years. So reviewing the previous data, as we know, the predominantly tumor were of adenocarcinoma of 75% in both the groups, involving distal esophagus and OG junction, involving T3 disease in 84% of the cases in almost both the groups with N1 disease. So what they found at the end of 10 years that even the neoadjuvant group have a 38% survival compared to 25% in surgery alone group. As we all know, squamous cell carcinoma again has an edge with neoadjuvant CTRT over adenocarcinoma, and the surgery alone group has the least survival. Coming to the mortality, so they have noticed that in a surgery alone group, the death by esophageal cancer is the highest, followed by neoadjuvant CTRT, and when the death from other causes like cardiovascular toxicity is equivalent between both the groups. So now coming to the recurrence, so what they noticed is the incidence of loco-regional recurrence is less in the cross group, only 8%, which was significantly less, but their distant metastasis was equal in both the groups. So what they discussed is the overall survival benefit that was observed in the first 5 years, it remains stabilized and persisted up to 10 years. Beyond 5 years, patient in both arms died at a comparable rate. There is a lesser risk from dying from esophageal cancer without an increased risk of dying from other causes. The better survival because of the decreased risk of loco-regional relapse because of the radiodesensitizing effect of the chemotherapy drug. But they have no long-term effect on the distant metastasis, and they mention that there might be a need of better systemic therapy for this problem. They have mentioned in their article that there are 2 studies, phase 2 TRAP studies, which have included trastuzumab and pertuzumab in HER2 positive adenocarcinoma that lead to increase in the pathological complete response with increased overall survival. However, on the contrary, RTOG 1010 study has mentioned that including trastuzumab has no significant difference in survival. So superiority is yet to be demonstrated. Now the last thing, as we know, cross has shown good response for squamous, but not for adenocarcinoma as compared to squamous. So FLOT 4 trial, which is for adenocarcinoma of stomach and OG junction, if you notice the overall survival with FLOT and cross is almost equal. So the ESOPAC trial, which is going to compare cross versus FLOT for esophagus and OG junction, will be next to see. The data is completed in this year, and we are going to see the results coming year. Now coming to the surgical approach, in the last decade we have robotics for esophagectomy, and with the advent of robotics, we have many retrospective studies which have compared robotic versus conventional thoracoscopic surgery. So this RAMI article, which was published in Annals of Surgery, is the first randomized controlled trial which have come with the early results of robotic versus conventional thoracoscopic surgery. So this is a non-inferiority trial published from China involving the 6 high-volume centers with all these surgeons have experience in more than 40 cases in both robotic as well as thoracoscopic surgery annually. Their aim is to find whether the technical advantage of RAMI can bring long-term survival benefits in squamous cell carcinoma. So they have included all resectable squamous cell carcinomas from T1 to T4A with N0 to 2 with all age group of 18 to 75 years, ECG performance status from 0 to 2, and they have excluded cervical, G-junction cancers, advanced inoperable or metastatic disease. So they have taken, after excluding 181 in the robotic arm and 177 in their laparoscopic arm. This is the port position which they have used during their approach. So if you see, neoadjuvant therapy was given only in 20% of both the arms, which is contrary to what we practice, and other parameters like gender, ECOG, tumor location, clinical status and staging was similar. So contrary to all these studies that was mentioned, this study has mentioned that total operation time, including thoracic as well as abdominal, the time taken by robotic arm is less than the conventional approach. The thoracic lymph nodes between the two groups is similar. The rest of the parameters are equivalent. Now when they are compared between the patients who have received neoadjuvant therapy, the lymph nodes, total number of lymph nodes along the recurrent as well as total number of lymph nodes was significantly high in the robotic arms as compared to the conventional thoracoscopic approach. The rest of the post-operative outcomes, all complications, pulmonary, anastomotic leakage, vocal cord paralysis, chylothorax were all similar in both the arms. So they concluded that the robotic arm has a superiority because of the shorter operation time, higher surgical efficiency and a better lymph node dissection in patients following neoadjuvant therapy. It is equivalent for post-operative recovery, post-operative complications and low post-operative mortality. But the limitation is because as in West and we are practicing mainly patients after CT-RT, this cannot be extrapolated right now, and it is not for the young beginners because they have a very experienced surgeons in both the arms. Now ICG is used in many cases in esophagectomy. So the first article that was on the thoracic duct delineation that was published in Journal of GI Surgery with impact factor of 3.5. This study, as we know, that post-operative chylothorax is a source of morbidity and mortality. So intraoperative identification and preservation is the important factor to prevent this injury. There are many techniques to identify thoracic duct, but this study aims to look for ICG, dye and NIRS, near infrared spectroscopy, to identify and rule out thoracic duct injury. So what to do in this? We have to inject 2 to 3 ml of indocyanine green into bilateral inguinal lymph node under ultrasound guidance in a dilution of 1 milligram per ml. And then you can see with the help of Karl Stroh's this Rubina overlay technology, you can see the clearly thoracic duct in view, and you can dissect with keeping thoracic duct in view to decrease the chances of any leak. There are various modes of ICG, overlay, monochromatic and intensity mode, where you can see thoracic duct clearly. This is the robotic phase where you can again see thoracic duct clearly and you can do dissection without injuring thoracic duct. And if there are tumor is involving the duct, you can clip it in keeping it in view. So they have 21 patients with the 15 thoracoscopic and 6 in the robotic groups. The time taken for ICG insertion was 15 minutes and the interval between dye insertion and visualization was around 35 minutes. So there was a 0 chylothorax in the study. There are 3 patients in which intraoperative clipping was required. One, it was unintentional injury which was missed on a standard view but visualized on ICG mode. 2 patients, it was involving the tumor, so it was ligated to achieve oncological radicality. So intranodal ICG technique is easy to perform, not time demanding and inexpensive. Can also be used during reoperative surgery for a chylothorax. Even a routine ligation of thoracic duct can be performed under revision. There is no iatrogenic injury at the injection site or any allergic reaction to ICG. Now the next article on the quantitative perfusion assessment of gastric conduit with ICG. This article is on McEwan esophagectomy, and this is a quantitative because till now we are using only qualitative assessment. So as we know, anastomotic leak is again a cause of morbidity. There are various factors for assessment of to prevent the leak, but impaired perfusion is one of the risk factors for esophagogastric anastomotic leak. So the aim of this study was the intraoperative quantitative assessment of gastric conduit perfusion. So they have taken all thoracoscopic and robotic assisted procedures, and the ICG fluorescence angiography was used, assessed with the help of SPY elite system from Stryker. There are two anatomic landmarks they have kept, one as tip of the gastric conduit and 5 centimeter behind it, that is point B. So these values they used to calculate. One is the ingress is for inflow, egress is for the outflow. The ingress time is the estimated time to reach the peak of the ICG, and the ingress index is the intensity of the ICG. So this is the graph is plotted after the with the help of SPY elite system, where you can see the ingress rate and the egress rate, which is important, and the ingress time. So what they found is, out of 70 patients which have a leak, the ingress time, that the time to reach the peak is higher, and the ingress index, the intensity was low when the patient, those patients who had leak. So they discussed that assessing the perfusion can help to predict those who are likely to leak. There are various techniques to identify it. We have tissue oxygen saturation study, thermographic study, microvascular circulation study, but ICG fluorescence angiography, which can quantitatively assess, provides a time-related value to evaluate the perfusion. You can divide the tip of the conduit to make the anastomosis in a well-perfused area, and the perfusion assessment can be used to better tailor the post-operative course so that we know which patients are going to have a leak. The limitation is they have recorded it for only 2 minutes, which could be 5 minutes to get a proper egress curve. But the important thing is to keep the gastric conduit immobile during the measurements. Now moving on to the stomach. As we know, laparoscopic distal gastrectomy has shown results similar to open distal gastrectomy. We have technical feasibility, we have results of recurrence-free survival, but this study, which was published in JAMA Surgery, talked about 5 years outcome of class 1 randomized control trial. So as we know, class 1 trial, which was published in 2019, showed there is no significant difference in DFS at the end of 3 years in laparoscopic versus open. The K goes for Korean and C for Chinese. The class Korean trial also showed the similar result, that the DFS is similar. This study is about 5-year overall survival after doing laparoscopic distal gastrectomy for locally advanced gastric cancers. So it's an open label multi-center randomized trial conducted at 14 centers in China. They have included.
Dr. Vaibhav, time is up. Can you just show the last result, and then we can open further?
So this is the
yeah.
So this is the results. 5-year overall survival is similar between the laparoscopic and the open group. It is across all stages. The restricted mean survival time was similar, as well as gastric cancer-related death was no difference. So this study, I have skipped the slides. This study has not used neoadjuvant therapy in any of both the arms. They have given adjuvant chemotherapy. So they have mentioned that this cannot be exploited in the Western world, where people use neoadjuvant therapy. So Logica trial, which was published from Western world, which shows that even after giving neoadjuvant therapy, the post-operative complication and oncological efficacy is similar. They have published 2 protocols for class 2 trial that will compare lap total gastrectomy with open for advanced cancer in upper body of stomach, and class 3 trial, again laparoscopic gastrectomy after neoadjuvant therapy. Thank you.
Thank you, Dr. Vaibhav. While the questions come from the floor, can I ask you that if you have a indocyanine perfusion which is not tops of the tops at the conduit, what can you do then?
Sir, we can divide the tip of the conduit and then do the anastomosis in the perfused area. This is the thing we can do.
Okay, but if it's substantially reduced, then the point is, was there did the data show that the pre-existing methods were insufficient in many cases, and this showed up many of them? Is this showing a different section of the patients?
Sir, ICG, though the standard protocol by visualization is the most important, but ICG in some cases will give you guidance that this tip
How
of the conduit.
frequent is that? I mean,
Sir,
I
if
don't
you are
use it,
doing
so I
100
want to know.
esophageectomies, then out of 10, you will find that this will be useful. That you can divide the tip of the conduit and you do anastomosis in the well-perfused area so that you can decrease anastomotic leak rate.
Audience, please.
So just in continuation, sometimes earlier I read, I don't remember the exact year, that there was a preconditioning, but without no ICG. You
Yes,
can
sir.
just clip the left gastric artery and then wait for 1 week and then go ahead again.
Sir, again, the preconditioning was done to increase the perfusion of the
Yeah.
stomach. So this is done on a intraoperatively. You can use ICG to assess the vascularity.
So please, question and comments from the audience.
What does the audience think? I mean,
So-
there are lots of surgeons who do a huge number of these conduits. Is there experience that there is a huge layer, creamy layer if you like, which shows up on ICG perfusion, which they were not aware when they looked at the patients?
So this shows that ICG is one of the methods to do that. Whether it is better than other methods that people are already using, you need to compare those. But that data is not available, so we cannot say that it is useful, whether
Correct.
it is
This-
clinically useful or not.
Head-to-head comparison is not there, but yes, it is useful. You can avoid
So
anastomotic
this is
leakage
one
in
of the
few
ways
cases.
you can do that, but there are other ways to do that also. You can do Doppler also. You can visual if you are
Absolutely
inexperienced, then you can see the tip is not of the pink color. So these are the things that you can use.
In doubtful cases, when you are having doubt, you can use this technology to confirm whether the vascularity is present or not.
Dr. Indian, first from this.
In Ramesh trial,
Please introduce yourself.
intrathoracic anastomosis, when you're comparing robotic versus lap, how many were intrathoracic anastomosis?
So these were all McEwan's esophagectomy, sir, cervical anastomosis.
Only cervic. Thank you.
Dr. Indian, please.
Just a comment regarding the ICG part. Just a comment regarding the ICG part that Dr. Ramesh was asking. So we actually did, one of our PG students did a thesis on this. We didn't find that it was extremely useful when we were asking the numbers. So that is just from our experience. Just one more comment on where you inject the ICG. You can also, instead of injecting into the lymph node, you can actually inject into the subcutaneous tissue of the groin as well. You don't need an ultrasound for that. And you just have to do it probably 8 hours before. This was probably 2 hours before, right? The timing of the injection?
Sir, the publication from Bachatio et al., they have injected it into the mesentery during the abdominal phase at the beginning. But in this study, you can inject into the inguinal lymph node just when the patient is supine.
Correct.
And
So
when
that
you
was-
do the patient prone position, like half an hour usually goes when the patient is making you have to make the position, clean, drape, put to the board. And by the time you go in, thoracic duct is clearly visible.
Correct. So if you're doing Ivor Lewis, perhaps you can inject into the mesentery. But if you're doing McEwan's, you will have
Yes,
to inject into
inject.
the lymph node. But that is just at induction. But if you, the previous night, let's say at 6, 7 p.m., if you inject into the, just into the groin subcutaneous tissues, you know.
That was previous study, but it is feasible with inguinal lymph nodes now.
Thanks.
So Dr. Puneet, just short comment, please.
No, just the cross-trial long-term results. We know that 25% of all upper digestive tract cancers will have some other. So just wondering, does this show that, since surgeons are relatively reluctant to adopt neoadjuvant techniques, is this some soft evidence to show that field cancerization effect might be lowered?
Yes, sir. For squamous cell carcinoma, no doubt, sir, it is beneficial. For adenocarcinoma, as I mentioned, ESOPEC trial will show whether we can avoid radiotherapy and give only FLOT regime for adenocarcinoma.
Thank you, Dr. Vaibhav. Thanks a lot.